Hi, how are you? My name's Eric Albert. I'm going to talk about ankylosing spondylitis. And just to keep it simple, I'm going to refer to the condition as AS. AS is a chronic inflammatory rheumatic condition and a group of conditions known as inflammatory arthritides. Simply said, it's an arthritic condition that affects the spine mostly and the sacroiliac joints of the hip. There's some other areas of the body that can affect, and we'll get into that a little bit later. Ankylosing spondylitis is characterized as a chronic spinal arthritis that results in the fusing of spinal vertebrae and sacroiliac joints. It's prevalent mostly in men, and most of the people that have it are found to be in North America and in Europe. Some of the clinical manifestations are, and the number one complaint that comes along with AS is chronic lower back pain. Has an insidious onset, and the onset of symptoms typically are between men the ages of 20 to 30. In order to be diagnosed with AS, they typically want the onset of symptoms to start before the age of 40. Back stiffness, and what's particular about AS and back stiffness is that the back stiffness for people with AS mostly happens at night when they're resting and when they first wake up in the morning when they've been resting all night. This back pain that's different from other back pains is that with rest it does not improve, and it actually improves with exercise and activity. Another clinical manifestation is reduced mobility. Because of the inflammation changes into the lower back, people with AS will have problems with rotational movements, flexation, bending at the hips, and so forth. Mostly that, and what they think is that a lot of people with AS suffer from fatigue, and that could be from multiple things. It could be from the condition itself or from the lack of wanting to move because of the pain, the chronic pain, and then just the anxiety that comes along with the condition. And then the other hallmark sign is sacroiliac joint pain, which kind of goes along with the lower back pain. There's some other clinical manifestations that we'll get into when we talk about the complications, but just to reiterate that the number one complaint that will lead somebody to this is back pain that gets worse with rest, back pain that started in someone's 20 to 30s, and then some other spinal curvature deformities that I'll talk about a little bit later. What they use to diagnose AS is a physical exam, and one thing that they're looking for is spinal curvature changes. And what happens here is because of the inflammation changes and the fusion of joints, is that people actually lose their lordosis in their lower spine and then end up with a hunchback in their upper spine. This also leads to decreased mobility, like we said before, with the rotational stuff and moving laterally, people lose that. And then because of the hyperkyphrosis that people can end up with, they actually lose the ability to expand their lungs. They actually lose chest expansion. A X-ray of the sacroiliac joint is one of the imagings that, whether it's an orthopedic doctor or your primary or so forth that's ordering this imaging, will look at. And what they're looking for is inflammation changes in the sacroiliac joint. Some of the lab tests that they do, they're looking for an elevated estimated SED rate. And then, surprisingly enough, even though this is considered a rheumatic disease, rheumatic factor will be negative in people with ankylosing spondylitis. The other thing they're looking for is an antigen known as HLA-B27. And what happens is there is a malformation or a disfolding of the proteins in this antigen, and that's one of the signs for this condition. Not everybody's going to have the HLA-B27, but it's just, one of the markers that they use to diagnose the condition. Now, there's two subtypes or two types of ankylosing spondylitis, and one is, and you can see here, one is radiological and the other one is non-radiological, and the only real difference between the two is when they do the x-rays of the sacral iliac joints, is one will show evidence of inflammation in the joint and the other one will not. You don't necessarily need it to diagnose the condition, because not everybody will have it, but there is a 20% chance of people that don't have it on their first radiology will develop it within 5 years. Some of the complications of the condition is enthesitis, which is inflammation where a tendon or a ligament is attaches. One of the biggest problems with people that have ankylosing spondylitis is enthesitis in the Achilles joint. So one of the things that they'll look at when they're assessing somebody for the condition is they'll look at their Achilles tendon and look for any signs of inflammation on either end. Dactylitis, which is also known as sausage fingers. So when people have these fat fingers and also with kind of like stiffening joints in their fingers, that's another sign of AS. People with AS have really bad hip pain because of the sacroiliac inflammation. They get a V pain in their hips, in their groin, lower back, so forth. It's all referred pain from the inflammation. And sometimes this requires hip replacements. Postural deformities, something we touched on before, which is the hyperkyphosis, loss of the lordosis in the lower spine, and then hip stiffness. And like I touched on before, this can lead to pulmonary issues or chest expansion because of the kyphosis. Peripheral arthritis, people can end up with. This is a centralized arthritis of the spine, but they can end up with peripheral arthritises. And another concurrent disease or condition that can be present with people with AS is inflammatory bowel disease. People can end up with Crohn's disease, ulcerative colitis, and so forth. One of the biggest problems is that when they're trying to diagnose somebody or they're looking at somebody for diagnostic purposes, and one of their main complaints typically is lower back pain. But AS can affect anywhere in the spine, and one of the areas that it does affect mostly in the progression of the disease, or even sometimes one of the earliest complaints, is cervical neck pain. And people can end up with vertebral fractures, and when they do end up with these fractures, they can end up with them in the cervical spine. So that's something that they have to look out for. And then one of the biggest, or one of the most severe complications, other than the vertebral fractures, is actually spinal cord compression. Spinal cord compression, nerve ending compression, and so forth, that can be affecting other areas of the body. Some of the treatments and managements that they do for ankylosing spondylitis is the first thing that they'll try is physical therapy to kind of strengthen the muscles and so forth around where the damaged areas are, the compromised areas are, to build supportive care around there. NSAIDs are the first line for analgesic therapy, and if those don't work, they will move on to opiates and so forth, or other kind of nerve pain, such as Neurontin, gabapentin, and so forth. Another therapy that they've tried to use is biological and non-biological DMARDs, which are your tumor necrosis factor inhibitors, and in this disease process, they use interleukin-17 inhibitors. Glucose corticosteroids, whether it's by oral or injection, if you want a systemic reaction or a localized reaction, so they do intra-articular injections also. And then this is a big factor when it comes to anybody that has to deal with chronic pain, and particular in ankylosing spondylitis, because it can reduce physical activity. People have to live with chronic pain, and this can lead to anxiety, depression, and so forth. So mental health support and treatment is a big factor in treating AS. And lastly, the reserve for last case would be surgical intervention, whether it's a discectomy, spinal fusion, and sometimes people require hip replacements. This is an overall overview of ankylosing spondylitis. Thank you for listening. Appreciate it.